the Ottawa ankle rules have been talked about ad nauseum, so I'm going to talk a little bit about some other aspects of foot and ankle trauma, some terms of management, follow-up care, and some unique types of foot and ankle injuries. This lecture stemmed out of a manuscript that I was writing for EM practice that got rejected, so I kind of turned it around and made it into a lecture. So in terms of learning objectives, what I want to do is review a little bit of the foot and ankle anatomy, both bony as well as ligamentous, because a lot of these injuries result from specific bony injuries or specific ligaments. It's important also in terms of grading of sprains, which ligaments are the most affected, and hopefully you'll also get some board review aspects about which types of ligaments are most often affected for certain injuries. So, this is kind of a shout out, give me you guys just to a quick review because, and if you're like me, navicular, cuboid, which is medial, which is lateral, always confuses me. So, let's see, number one, what are those?
First and third.
Metatarsal, perfect. So, starting out easy. All right, number two.
Cuneiform.
Cuboids. No. Cuneiforms.
Cuneiform.
Yep. Good thing we're doing them.
Yeah.
So, cuneiforms, right? There's three of them, and they're all on the medial aspect. What's number three?
Navicular.
That's your navicular, right? So it kind of looks like a boat. Think of the Navy, upside down boat. Number four, phalanges. And number five?
Cuboid.
That's the cuboid.
Calcaneus cuboid, CC.
That's a good way of remembering it.
Yeah.
Cool. So number six?
Talus.
That's your talus, right? So we'll talk a lot about the talus today. And last but not least, calcaneus, and we'll talk about the calcaneus as well. So in terms of ligaments, fortunately, they're named from their origins and insertions. So obviously number one is going to be your fibula. So what do you think number two is? Which ligament is that?
The fibular talar ligament.
So is it anterior or posterior?
Posterior.
Okay, so it's posterior and it's connecting.
Oh, number two. Sorry, I couldn't ask number three. Sorry.
So it's connecting the fibula with the
Tibular.
yeah. So this is going to be your posterior tibulofibular ligament, and this is important when you start talking about higher grade ankle sprains, and also when we talk about what they call the high ankle sprain, and we're going to talk. And so if you tear the posterior tibiofibular ligament, those are really high impact injuries. So what about number three? What is that?
That's the fibular tip, I think.
So most of them are named from location, anterior and posterior. So it's anterior, right? And it's hard to see, but it connects the talus
To the fibula.
to the fibula.
Yeah.
So this is your famous anterior talofibular ligament, right? Why do we care?
Most common.
This is the one that's most common fracture, torn ligament, and this is that's the classic board question. Good. So number four is your calcaneofibular, and this one, as well as the anterior tibulofibular, the complex of the talofibular, the anterior tibiofibular, and the calcaneofibular makes up what's torn with a lateral ankle sprain. Most ankle sprains are more medial because of inversion injuries, but you can actually sprain the ankle laterally, and those are the ligaments that are involved. And so this is what it looks like. Obviously, the bones look like in an X-ray. There's, and then the one thing is, if you notice here, what are these? Sesamoids. And if you notice this one, this is just a nice incidentalloma. What do you notice about this sesamoid? Bipartite, right? So in the right setting, it could look like a fracture, but for the most part, this is just a normal anatomical variant. So the bipartite sesamoid. So just to talk a little bit about epidemiology, why do we care? Why are we spending so much time on this? Foot and ankle injuries are extremely common in the emergency department. There's about 23,000 visits per year for foot and ankle injuries. That includes both fractures as well as sprains. So that's about 1 in 10,000 visits for an ankle sprain. And that's the most common lower extremity injury in adults are ankle sprains. So you're going to see these patients. In children, fractures are actually more common, and I think it has to do with just how pliable children are and that they're more likely to actually fracture the ankle as opposed to getting an ankle sprain. And about 10% of all lower extremity fractures are foot fractures. So you diagnose a basketball player with an ankle sprain. You did the whole Ottawa ankle rules. You decided whether or not to X-ray him. And you decide that he does have an ankle sprain after his inversion injury. So what I want to talk a little bit about grading of ankle sprains, because once you make the diagnosis, it is important to kind of to grade them, because your management and follow-up will differ depending on the grade. And then the treatment also changes a little bit depending on the grade of sprain. And this table just summarizes. Ankle sprains are graded grades 1, 2, and 3. Grade 1, I'm sure you've all had. Again, it's the most common lower extremity injury. I'm sure we've all sprained our ankle. We've walked off the curb, twisted our ankle. Most of the time, nothing happens. You get maybe a little bit of swelling, but you're weight bearing. This is a grade 1 sprain. There's no ligamentous disruption at all. Grade 2 is a little bit more serious. It generally just involves the anterior fibular ligament, and they can get a partial tear. And the way you diagnose this is with a physical exam of the positive anterior draw, and I will demonstrate those for you in a few minutes. Grade 3, these are the most serious. These are those really swollen, ecchymotic joints. The patients cannot bear weight, and they're going to have what's called a positive talar tilt as well as a positive anterior draw. So those are the physical exam findings that you can use to differentiate between those two types of sprains. And this is again a visual representation. So grade 1, you just have stretching of the ligaments of the ATFL and the calcaneofibular ligament, but you also in grade 2, you have a partial tear of the ATFL, and the calcaneofibular ligament is still intact. It's just stretched. But in a grade 3 sprain, both are ruptured completely. And again, they're very swollen, tender, and the patient will not be able to bear weight. So again, how do we differentiate? We can use an anterior draw test, which tests the integrity of the anterior talofibular ligament. Basically what you do is you put the ankle in about 20 degrees of dorsiflexion, stabilize the tibia and the fibula, and just like you do an anterior draw test for the knee, you do it for the ankle. And again, it's not necessarily a degree of give, but it's the quality of the endpoint. It's in a nice firm joint. And most people, it's not going to have any laxity if you have a normal ankle joint, but you want to feel a nice firm endpoint. While the talar tilt, what you're going to do is you're just going to, again, stabilize the tibia and the fibula, and you're going to invert the ankle, so almost reproduce the injury. Usually you won't have any give, and what you're measuring here is the amount of give between the tibial plafond and the talar dome. And for most people, you're not going to get any give. But for somebody who's got a grade 3 ankle sprain, they're going to give almost 5 millimeters, which is kind of gross actually, because you're pulling it apart by almost half a centimeter, and you'll feel that give. The problem with this is, though, that a lot of these maneuvers, if they're really acutely injured, they're not going to be able to tolerate this. You're not going to get a good exam because they're so swollen. And what they've actually shown is if you actually delay these tests for 3 to 5 days, you improve the sensitivity up to 96% and the specificity to 84% for diagnosing ligamentous injury. So if you've got someone who had an ankle sprain that's really hot and swollen, you can't go and manipulate the joint to see if there's any laxity. Treat them like a grade 3 sprain, which means you're going to immobilize them and then have them follow up with ortho in 3 to 5 days where they can go and repeat the exam. Because grade 3 sprains, they may need actual surgery eventually to stabilize the joint. So if you can't figure out if it's a 2 or a 3, just splint them and send them off to the orthopedist. For grades 1 and grades 2, we talk about RICE, right? Rest, ice, compression, and elevation. Grade 3, again, is the only type of sprain that you're going to want to immobilize. But what's the evidence behind it? Do we know if RICE actually works? What's really interesting is they never actually studied all 4 components at the same time. Whether if they take one out or the other, they've just looked at rest alone, they've looked at ice alone, sort of compression and elevation. What they found actually for grades 1 and 2 sprains, rest is actually detrimental. You have better return to work if you do immediate range of motion tests, And that seems to be the trend for most orthopedic injuries. I don't know how many of you know, my husband just fractured his hip 4 weeks ago. They had him walking the day after, after he had surgery, because you want to get up there, you want to mobilize the joint. So for simple grade 1 or 2 sprains, you want to tell your patients, get up there, get out, and get moving. What you can tell them to do is simple range of motion exercises. There's no benefit of getting a wobble board or something like that. All you can do is tell your patients, while they're sitting there, and you guys can do this too while you're sitting in lecture if you've had ankle sprains, is just trace the alphabet. Make an A, a B, C, and what that does is it brings the ankle through all the ranges of motion, and you're strengthening the ligaments. And so while they're icing and sitting there, then you can, they'll be doing what they need to do to get better. In terms of ice, there's really no study in the best way to give ice. They say put it on for about 20 minutes every hour or so while awake for about 72 hours, but there's no real evidence behind how much icing you need to do. In terms of compression, a simple Jones dressing, ACE wrap, ACE bandage, the cheap, Kings County Way works just as well as the commercial products such as ACE, the air casts and all those things. So a simple ACE wrap or a simple Jones dressing. Do you guys know what a Jones dressing is? So you take a...
Bulky Jones?
Bulky Jones, yeah. So you take a layer of the cast padding, the soft cotton web roll, and put an ACE wrap over it. And it gives you nice compression, but it also stabilizes the joint a little bit. So in terms of pain medicine, it's really important that you do give your patients pain medicine. There hasn't really been any studies in terms of analgesia specifically for musculoskeletal injuries. They've had some, the initial studies used diclofenac versus Tylenol, and diclofenac worked better for musculoskeletal sprains, and therefore people recommend NSAIDs. And that's why that's kind of gone on to be the standard treatment. There is some talk that NSAIDs actually increase edema, but what they actually think is happening is that the Motrin works so well that people think they feel better, and they start to, instead of just doing simple range of motion exercises, they feel so much better they go out and then overdo it. And that's what they think is causing the edema. And if Sopranos, yes?
Just a question on that. So, in the early literature, there was some talk about NSAIDs might interfere with the healing of fractures. Do you have anything to say on that?
It's that was a study with like 12 dogs or something like that. It's purely anecdotal. Again, with my husband who had major hip surgery, they said Motrin is the way to go now. So even our orthopedic, because when I broke my clavicle in my a couple of years ago, they were still saying, no, you shouldn't be using Motrin, but I had to go to work, so he didn't want me in CCT on Vicodin. So I used the Motrin, and it worked just as well. And now even the orthopedists are saying use ibuprofen, because head-to-head, opioids don't do any better than Motrin. So if the patient tries to tell you, oh no, Motrin doesn't work for me, don't buy it. It works wonderfully. So even if you feel that they need a short course of an opioid, make sure that you prescribe the NSAID as well. So you have a football player, and you read about him in the morning papers, and they said, oh, he's on the sidelines because he has a high ankle sprain. Have you guys heard this term before?
Yes.
Do you know what it means? What's a high ankle sprain? Exactly. So this is the injury to the syndesmosis. And what's the mechanism? Do you remember?
It's like a twisting.
It's a torquing. It's like a forced external rotation.
Exactly. So usually the foot is planted, dorsiflexed, and you evert the ankle. So again, most ankle sprains are inversion injuries. These high ankle sprains result from an eversion injury while you're internally rotating the tibia. So it's almost like a clipping injury, sort of. And so I want to talk a little bit about what injury you get through there and how we diagnose it. So again, as we said, it's an eversion injury on a dorsiflexed planted foot. And what this is doing now is it's rupturing not just the anterior tibiofibular ligament, you're now rupturing that posterior tibiofibular ligament. So this is a much more serious injury, and therefore you're also getting the syndesmosis, so this interosseous membrane as well. And in terms of diagnosing on physical exam, there's a couple of maneuvers that you can do. You can, instead of just doing a talar tilt, which was a medial inverting it, you can evert the ankle and reproduction of pain kind of in the calf area or in between the tibia and fibula is a positive test. You can squeeze the calf, or you can do what's called a cross-leg test. So the cross-leg test, just like it sounds, you have the patient cross their leg over. You're going to put a medial force to externally rotate the knee, and then they're going to get pain right over the syndesmosis as a sign of a positive test. The one that I generally use is the squeeze test, where you just kind of squeeze the calf, because I'm examining this fibular head anyhow, right? Because with anyone who sprains their ankle, you always want to examine the fibular head, because you don't want to be that person who misses a Mason-Evans fracture, right? So as I'm moving up and I'm examining this fibular head, I also squeeze the calf. And if they have tenderness, you should have a high suspicion for a syndesmotic injury. But the problem is these tests aren't really good. About 20% of syndesmotic injuries are missed based on physical exam alone. And if you're seeing, that's 1 in 5 of your 10,000 ankle sprains that you're seeing every year. So what we do is we can actually so these patients are going to get x-rays anyhow, because they're going to be at high risk of fracture as well. And so they're going to get an x-ray, and you can use 3 different measurements to determine if they have signs of a syndesmotic injury. The first is what they call the tibial overlap. So the fibular and the tibia overlap here. And then you have the tibiofibular clear space, which there shouldn't be any clear space, which is measured about 1 centimeter above the tibial plafond, which is this area right here. And then the third is the tibiotalar or medial clear space. And so, just for your numbers, this overlap should normally be greater than 6 millimeters. So if it's less, so meaning this tibia kind of looks like it's out in space over here, that's highly suggestive of a syndesmotic injury. And so, and then for the medial clear space, usually this should be about 4 millimeters. If it's greater than 10 millimeters, you have signs of a syndesmotic injury. Yes?
Does it start with the AW, the Morse view, or the AC?
This is on, you can do this just on the regular on your regular AP. So you can do this on when you're getting your normal. It's just another thing to look at, because we often kind of gloss over these injuries. Oh, nothing's fractured. But to take those couple seconds to just make sure those measurements are okay is a good practice to get into, because again, these injuries are often missed. Yes.
I want to say you'll get a better effect if it's weight bearing.
Yes.
If it's standing,
yeah,
you're going to spread it more.
Exactly. So if you Mark, if you're really suspicious because they've got a positive squeeze and this looks okay, you can also get the weight-bearing views as well. And in terms of treatment, if they're minor and their weight, they can do some weight-bearing, and early range of motion, you do rice treatment, you can do early range of motion, training. If you're an athlete, then you're to really rehab this, you want to tell them that after they start feeling better, they should do hopping and skipping, hopping, weight-bearing exercises to improve it, to improve your range of motion. But why do we care? Why do we care about this injury? Because the recovery time for a high ankle sprain is much more than a regular ankle sprain. So the average time for recovery for a syndesmotic injury is 45 days. That's a month and a half compared to 1.25 days for an ankle sprain. And this study was done in professional hockey players. So these are guys who want to get back on the ice. They want to go and earn a living playing hockey. So you and me, our recovery time is probably even longer than that. So these are serious injuries in terms of recovery time. So changing gears a little bit. So and I know a lot of you guys go out snowboarding. This is a 23-year-old snowboarder who presents with pain to his lateral ankle. And besides the positive radiology sign, what do you see?
A bone fracture.
What bone is fractured?
Okay.
Talus. Okay, so you've got this fracture here of the medial or lateral aspect of the talus? Lateral. All right. So the whole talus is this bone right here. This is your talar dome, and this is your calcaneus. So this is almost a PA view, and here you've got this fracture right here. But it's much easier to see, and this is what's called do you guys know what this is called? It's actually called a snowboarder's fracture. And what it is, it's a fracture of the lateral process of the talus. So it's right here. And the way this happens is that you're planted everted, and then you have forced dorsiflexion. And so that causes this fracture of the lateral process of the talus. And on the lateral view, you can get this V shape right here, and that's very, very suggestive of a snowboarder's fracture or a lateral process fracture of the talus. And here's another view again. So you've got this V-shaped deformity right here. And it's called a snowboarder's fracture. It's much more common in snowboarders, but you can get it other ways as well. Skateboarders can get this, and you can also get it car accidents when you're planted on you're forcefully dorsiflex while you're pressing the brake in the car accident. That can also cause this type of fracture. And the reason we care, again, much higher incidence in snowboarders, but there is a high risk of malunion. So if you have to be highly suspicious of this injury, especially if they have tenderness about 1 centimeter inferior to the lateral malleolus. So if you have, the Ottawa ankle rule always talks about 1 centimeter above, but if you're suspicious of a snowboarder's fracture, you want to look for 1 centimeter below the distal fibula over the talus. And if they have tenderness there, but the x-ray looks negative, you do want to get a CT because they have a high risk of malunion and they may need to go to the operating room to get it fixed. So you have a 35-year-old female who jumps from a balcony. So what injuries is she at risk for? Calcaneal fractures. So how do we make a diagnosis of a calcaneal fracture? You can do dedicated films, but if you just, is there a way we can do it on just your regular films? Bowler's angle, right. So, what do you guys see here? So you've got this line right here, here on the lateral view, and then you've got this deformity right here as well. But they're not always this obvious. Right. So we can get something that's called a bowler's angle. And so what we do is we trace a line from the upper edge of the calcaneal body to the upper edge of the posterior facet, and then another line from the anterior process of the calcaneus and to the upper edge of the posterior facet. And what that looks like is like this. And this angle here is usually between 28 and 42 degrees. So I just remember 30. It's just much easier. So that's usually between about 30 degrees. But if it becomes more acute, so if you go down to 20, you should be highly suspicious if it's less than 25. That usually has a sensitivity of about, it has a sensitivity of 100%, but a specificity of about 84%, and a likelihood ratio of about, that you're 5 times more likely to have a calcaneal fracture if your Bowler's angle is less than 25. If it's less than 21%, you're almost guaranteed to have a calcaneal fracture. So it's really important to measure that, because you can't always necessarily see a calcaneal fracture on X-ray. And the other thing is, it's kind of a trick question, right? We talked about that calcaneal fractures can happen from a jumper, but you also have to look out for other injuries. So 6.4% of all calcaneal fractures have associated lumbar fractures. So you have to go and take a look for those other injuries, because they can be just as devastating. I think my time is up, so I just wanted to just review what I really want you guys to take home. Is, again, grading of ankle sprains is important in terms of management. Grades 1 and 2, you want to make sure that they can do rest, rest, compression, the RICE treatment. For grade 3, they actually do better with immobilization. If you think it's a grade 3, you can delay diagnosing it and put them in a splint and send them to the orthopedist. I want you to remember Bowler's angle, Snowboarders fractures is a lateral process fracture of the talus. And that's my two.